Good afternoon, everyone.
Yeah,
Pediatric
yeah.
Center of Excellence, JNIMS, Manipur, welcomes all the participants for today's Regional Distance Learning Seminar session. Today's topic is DTG 10mg Overview and Case-Based Discussion, and the speaker is Dr. N. Kameshore Singh. Dr. N. Kameshore Singh, sir, is currently the professor and head of pediatrics at JNIMS Imphal and the program director at pCoE JNIMS. With over 2 decades experience in the state health service as a pediatrician, he is a distinguished recipient of the Pioneer Award from the East Zone Academy of Pediatrics in 2005. He has extensive experience in HIV/AIDS, having attended numerous NACO, WHO, and UNICEF trainings. He holds key positions in the Indian Academy of Pediatrics, Manipur State, and the East Zone Academy of Pediatrics. He has published many papers in both national and international journals. He has also presented papers in state, zonal, national, and international conferences. We welcome you, sir, for today's session and request you to start the session.
Uh, Thank you, Dr. Sweta. So, we'll have discussion on DTG 10 milligram overview and case-based learning. So, I request Sweta to share the slides. So, the objectives of this session is to discuss and understand the national guidelines on dolutegravir 10 mg based ART regimens mean for children living with HIV. So in this, we will discuss first-line ART regimens in ART-naive children weighing less than 20 kg, DTG 10 milligram dosing in TB-HIV co-infected children, transition to DTG 10 milligram based ART regimens in children weighing less than 10 kg, and also counseling caregiver for DTG 10 milligram based ART regimens. At the same time, we have to monitor children on DTG 10 milligram based ART. Next. So let us recapitulate the goals of ART in children living with HIV. With ART, we can suppress HIV replication, preserve, enhance, or reconstitute the immune system, and therefore we can reduce the incidence of opportunity infections. By doing so, we reduce the morbidity and improve the quality of life in children. We promote, ART promote optimal growth and development and prolong the survival. Next. So let us see what are the steps while preparing a child for ART. So the first thing is we have to identify a primary caregiver. Primary caregiver is usually parents, and it may be other family members also. And many times we may need to identify a backup caregiver if the primary caregiver is a PL-HIV. So at first, we have to do initial assessment of the child, including baseline clinical and laboratory assessments, evaluation, diagnosis, and management of opportunity infections, including tuberculosis, is to be done. Baseline psychosocial assessment of caregiver and the child also to be done. Initiation of cotrimazole preventive therapy, usually known as CPT, is very important. And ART preparedness counseling is to be done, preparing the child as well as the caregiver for lifelong ART. We should stabilize the patient before ART initiation, which is very important to prevent IRIS, that is immune reconstitution inflammatory syndrome. Next slide. So, recapping the steps in ART initiation in children living with HIV. The first thing is confirmation of the HIV infection in children and infants. In infants and children less than 18 months, we have to do virological testing, and more than equal to 18 months, we have to do serological testing. Then we have to perform baseline assessment investigations, including CD4 counts, and we have to treat and stabilize acute conditions and opportunity infections before ART. Then we should initiate CPT, that is cotrimazole preventive therapy, and prepare caregiver and assign for the lifelong ART. Then we should initiate appropriate first-line ART. Now it is given regardless of the age group, the clinical staging, or immune status of the child. That is CD4 count. Next. So repeat ART initiation also can be done in children living with HIV/AIDS, and it is advised in children living with HIV after appropriate preparedness counseling, and it is to be initiated regardless of the CD4 count, the clinical staging, which I have already mentioned. But remember, ART is not an emergency intervention. We have to do treatment preparedness and management of opportunity infections prior to ART starting. Seriously ill and hospitalized children should be stabilized before ART initiation. Next. Next, please. Oh, so dolutegravir-based ART regimen in children. Dolutegravir, DTG, is very important, more potent drug, repeatedly actives and maintain viral suppression. DTG supports adherence through less pill burden and easy administration. So there is evidence of superiority of DTG compared with ritonavir boosted lopinavir, and at the same time, it harmonizes with the adult regimen and therefore easy for maintaining supply chain also. Next. So let us see the advantages of DTG 10 milligram dispersible tablets, which are used in children. So simplified dosing schedule, then easier administration, better tests, better tolerance, and less side effects. It gives faster viral load suppression and also high genetic barrier for resistance. These are the advantages, important advantages. Next. So let us see what are the key considerations in pediatric ART regimens. So we all know that abacavir is the preferred first-line NRTI for ART initiation in children living with HIV. Lamivudine is the second nucleoside reverse transcriptase inhibitor component for all patients and is taken as the backbone of the ART. Children living with HIV less than 20 kg will be initiated on dolutegravir 10 milligram base regimen, and for children whose weight is more than equal to 20 kg, dolutegravir 50 milligram film coated is recommended as the preferred third drug. And for all children age more than equal to 10 years and weight more than equal to 30 kg, tenofovir is the preferred first-line NRTI drug for ART initiation in children. Next. So let us see the ART, previous slide, please. Let us see ART regimen in ART NIMS, children living with HIV. Dolutegravir 10 milligram dispersible tablet is advised, as mentioned already, in less than 20 kg children. Dolutegravir 50 milligram film coated tablets can be used in children more than equal to 20 kg who can swallow the tablet, and the tenofovir 300 milligram is advised in children living with HIV with age more than equal to 10 years and weight more than equal to 30 kg. So let us see what is the recommended first line regimen. So weight less than 20 kg, AL and the dolutegravir. This is the fixed drug combination of abacavir, lamivudine as per the weight band, which is given twice daily, and the pediatric DTG, 10 milligram tablet per weight band, which is given once a day. And for children between 20 to 30 kg, we give ALD, which is fixed drug combination of abacavir and lamivudine, which is given twice daily as per the weight band of the child, and plus dolutegravir 50 milligram film coated once a day. For children above 30 kg and age above or equal to 10 years, we give PLD, which is the fixed drug combination of tenofovir, lamivudine, dolutegravir. Here we give once daily. And this is as per the national guideline. And for pediatric drug doses are, we should always this keep reference to the printed pediatric drug dose chart, which is given in the Annex 2 of the ICIV care and the treatment 2021. Next. So this is the pediatric drug doses chart, which is to be printed and always keep on the table so that you always do the confirmation of the drug doses as per the weight band of the child, as per the recommendation, what ART drugs is to be used. Next. So ARV drug dosing for CL ICIV weighing less than 20 kg. So let us see the prescription here. If the child's weight is between 3 to 5.9 kg, then we give dolutegravir 10 milligram DT tablet once daily, half tablet. And the abacavir and lamivudine, which is 60 by 3 milligram, twice daily, one tablet. And if we give ZL, we give 60 by 30 milligram of ZL twice a day is one tablet. So if the weight is between 6 and 9.9 kg, dolutegravir comes as 1.5 tablet. Previous slide, please. 1.5 tablet, and AL also 1.5 tablet, but twice daily. ZL also 1.5 tablet, twice daily, and weight between 10 and 13.9 kg. Dolutegravir 10 milligram comes as a once daily of 2 tablets, and AL twice daily of 2 tablets each, and the ZL also 2 tablets twice a day. And if the weight band is between 14 and 19.9 kg, then dolutegravir comes as a 2.5, that is 2.5 tablets, and AL also 2.5 tablets twice a day, and ZL also twice a day of 2.5 tablets. Next. Or remember that 30 milligram dispersible DTG is equivalent to 50 milligram film coated DTG. Next. So then the very important step, next step is preparedness counseling for DTG 10 milligram base ART. So we have to explain what is to be taken, when is to be taken, and who is to be given the medicine in children. So DTG 10 milligram is a dispersible sport tablet, and we have to explain that a dose must be repeated if the child vomits within 30 minutes of taking the medicine. This is the usual for children while giving medications. And when to be given? DTG 10 milligram can be taken with or without food. Dose is once a day at a fixed time. And ensure that the timing is linked with the routine of the child as per the child's requirement. And we have to identify who is going to give the drug. So primary caregiver should give the drug. Usually the mother is the primary caregiver. The father can also give, grandfather, parents or guardian also can give the drug to the child. And it is essential to identify a backup secondary caregiver, particularly when the parents are having HIV infection. Next. So we have to explain to the caregiver and the older children how to give DTG 10 milligram dispersible tablet. There are 10 steps to describe this. DTG 10 milligram DT tablets are dissolved in drinking water in a clean cup or glass. Then we have to take required number of DTG 10 milligram tablets in a cup and add measured amount of water. For example, if we have to take this half a tablet to up to 4 tablets, we can use 5 to 10 ml. That is 1 to 2 teaspoonfuls. 1 teaspoonful is equal to 5 ml. So if we are giving, while giving DTG 10 milligram with either AL or ZL dispersible tablet, we can use 20 ml of drinking water or that 4 teaspoonfuls. So that is to be maintained. So the fourth point is that the suspension should be swirled so that no lumps remains in the container. The fifth point is that the oral suspension should be given immediately, preferably within 30 minutes of mixing. Step 6 is add a small amount of water in the cup in which medicine was prepared just to give all the doses. And this is step 7, that additional water to cell HIV to ensure full doses of drugs. The 8th step is DTG dispersible tablet can be swallowed whole if the child is beyond 5 years of age, and 1 tablet at a time should be swallowed to avoid choking if more than 1 tablet is taken. Step 9 is score DTG 10 milligram tablet can be split with dry and clean hands. Unused half tablet needs to be returned to the bottle, which is the 10th step. Next. So now let us see, can we give DTG 10 milligram, 3 tablets for cell HIV weighing 21 to 29 kg? Because sometimes it may be difficult by this children of weight category 21 to 29 kg, they may have some difficulty in swallowing the tablets. Let us see what is the recommendation. Recommendation is that DTG 10 milligram dispersible tablet is meant for children below 20 kg. If the child is equal to or above 20 kg, then it is recommended to use 50 milligram film-coated DTG tablet. But there is an option for children equal to or greater than 20 kg who are not able to swallow the film-coated tablets. Then the 50 milligram tablet either may be split into halves, followed by immediate ingestion, or both halves of the tablet, or crushed and added to a small amount of semi-solid food or liquid, all of which should be consumed immediately. So this is the recommended option. Or if cannot to do at all, we can give 10 milligram DT dispersible tablet given in a dose of 30 milligram, because 30 milligram DT is equivalent to 50 milligram film-coated DTG tablet. Next. So we should know whether this DTG 10 milligram tablet can be taken with food or meal. Yes, this can be given with food, with meal, and also can be given without meal. if you are giving with water, it should be ideally dispersed in water or can be given with food or milk. And as it is a dispersible tablet, should be dispersed into a solution and given. So according to the convenience of the caregiver and the child, you can always choose either of these recommendations. Next. So counseling is very, very important to the caregiver as well as to the child living with HIV. So we have to explain the need for lifelong ART and at the same time, importance of adherence and viral suppressions. We have to explain the benefits of DTG 10 milligram, which is very effective, safe, and easy to administer. We have to explain the uncommon side effects, particularly insomnia, fatigue, headache, rash. But rash is to be, of course, these side effects are to be reported immediately to the doctors. Explain about the possible weight gain due to DTG and the exercise and the nutrition counseling to be given accordingly. Explain how to give the drug. We have already mentioned the 10 steps which are to be followed. And we have to specify dosing, which is weight-based, and those will be sensed, has to be sensed as the child gains weight. This is very important. We have to advise regarding the fixing of the time of giving the drugs. DTG should be taken 2 hours before and 6 hours after taking cation containing antacids and laxatives, and also sucralfate, oral iron supplements, and oral calcium, etc. Next. So let us revise again important drug-drug interactions while giving dolutegravir. So if the child is taking carbamazepine, then we have to use twice daily dose of DTG. Otherwise, we have to see for a substitute of the anticonvulsant agent. While giving phenytoin and phenobarbitons, we have to use an alternative anticonvulsant agent to avoid phenytoin and the phenobarbital. If we are taking, as mentioned earlier, polyvalent cation products containing aluminum, calcium, iron, magnesium, zinc, etc., antacids and multivitamin supplements, then we have to give dolutegravir 2 hours before this medication or 6 hours after this medication. As in carbamazepine, if rifampicin is given as an ATT, then we have to use DTG twice daily dosed. And amodiaquine, we have to see for alternative anti-malarial agent. Next. So let us see some case scenarios. The first case scenario, let us see Miss Y, an HIV-infected child, has 2 years. She has persistent oral thrush. She has achieved normal developmental milestones, but has failed to gain weight and height as expected. Weight is only 6 kg, which is less than 3 Z-scores. Height is 72 centimeters, which is also less than 3 Z-scores. CD4 count is 18%. Hemoglobin is 7 gram deciliter. Of course, TB has been ruled out. What is the clinical staging of the child? No doubt, because of severe malnutrition, it is clinical stage 4. And as the child is having severe malnutrition, it should be evaluated by a pediatrician, preferably. And the second question is, CPT indicated in this child or not? Yes, CPT is indicated in this child. because the child is less than 5 years. And if the child is less than 5 years, irrespective of the clinical stage and CD4 count, we have to give CPT prophylaxis, that is cotrimoxazole preventive therapy. Next. So cotrimoxazole is given, which contains trimethoprim 40 against 200 of sulfamethoxazole for every 5 ml. So the dose comes as 5 ml once a day cotrimoxazole in this child of 2 years. Next. Continuing the scenario 1, let us see what needs to be done before ART initiation. As we have already discussed, before ART, we have to do baseline clinical and investigations, and including CD4 count and the percentage. At the same time, we have to do screening and management of opportunity infections, including tuberculosis. And the 4S is used for the screening of tuberculosis, and which are the fever, cough of any duration, failure to gain weight in children, and history of contact. Preparedness counseling after identification of the caregiver and the backup counts this caregiver whenever required. CPTs initiated if less than 5 years, and check for his adherence in initial visits. And we have to use, very importantly, the malnutrition. And sometimes for this, you may require, the child may require hospitalization. Then question number 4, let us see what ART is to be prescribed in this index case. That is 2 years, weight 6 kg. So the weight is less than 20 kg. We will give DTG 10 milligram and abacavir and lamivudine. So the dose is abacavir lamivudine 60 by 3 milligram tablet, one and a half tablet twice daily, and dolutegravir 10 milligram, which is also 1.5 tablet, but once daily. So this is the ART of this child. Next. Again, we are, let us summarize ART initiation in an ART naive CLICIV. So the first thing is confirmation of the infection, virologically or serologically as per the age of the child. Then we have to treat and stabilize acute condition, opportunity infections, and we have to do baseline investigations, including CD4 count. After that, we have to come what is the age and the weight of the child. If the weight is less than 20 kg, as we have already discussed, abacavir, lamivudine, and dolutegravir 10 milligram tablet is to be given. If the weight is between 20 and 30 kg, then we choose abacavir, lamivudine, dolutegravir 50 milligram film-coated tablets. And if the weight is more than 10 years and body weight is, if it is body weight is still less than 30 kg, we come between the 20 and the 30 kg category. And if the body weight is more than 30 kg or equal to 30 kg with age equal to or more than 10 kg, we look, is there any renal disease? If the renal disease is not there, then TLD, that is tenofovir, lamivudine, and dolutegravir. If the renal disease is there, this child will come to the category between 20-30 with abacavir, lamivudine, and dolutegravir. Next. So remember, the dose of the ART is based on the weight band of the child. And for this, always keep the pediatric dosage chart at your table. Next. So this is the actual prescription writing of the ART. of ART in children living with HIV. So in a child of 6 years, weighing 13 kg, male child hemoglobin 8 gram deciliter with CD4 count of 500 cells per cubic millimeter. Then as the weight is below 20, and we will give abacavir lamivudine 60 by 30 milligram, 2 tablets twice daily. DTG 2 tablets once daily of 10 milligram. As the hemoglobin is 8 gram per deciliter, we can add hematinic syrup of iron, elemental iron in the dose range of say 2 to 6 milligram per kg per day. If the child in the second scenario, if the child 7 years old child, weight 19 kg female, hemoglobin 9 gram deciliter, and CD4 300 cells per cubic millimeter, and no OI. Here, the ART is 2.5 tablets twice daily of abacavir lamivudine 60 by 30 milligram tablet. DTG 10 milligram tablet, 2.5 tablets once a day. As CD4 count is 300, though the child is above 7 years, we will give cotrimoxazole. And cotrimoxazole, we can select SS tablet, 1 tablet once a day. And we can give other supplements also, folic acid, for example. In the third situation, 3 years old, weight 9 kg, male child hemoglobin is unavailable, CD4 count is 400 per cubic millimeter, no OI. Here, 9 kg, the tablet comes as 1.5 tablet of AL 60 by 30 milligram tablet twice a day. And DTG also 1.5 tablet once a day. Here, as the child is less than 5 years, irrespective of the CD4 count, we will give cotrimoxazole prophylaxis, and the dose is 5 ml once a day. In the fourth category, 4.5 months old infant diagnosed HIV infected, weight is 4 kg, no OI. Here, less than 4 kg, the AL 60 by 30 comes as 1 tablet twice daily, and the dolutegravir comes as a half tablet once daily. As the child is below 5 years, we give cotrimoxazole prophylaxis. We start cotrimoxazole prophylaxis in exposed babies from 6 weeks. Next. So let us see case scenario 2. Master Z is a 2 years, 9 months old HIV infected boy who presented with altered sensorium since 2 days, cup with fever for the last 1 month. His father was recently detected to have pulmonary tuberculosis. He was diagnosed to be suffering from tuberculous meningitis. So contact with cough and altered sensorium tuberculous meningitis. He was started on anti-TB treatment for 14 days ago. His body weight is 9 kg, CD4 count is 14%, hemoglobin is 9.8 gram percent. Is CPT indicated in this child living with HIV/AIDS? So 2 years and 9 months, less than 5 years, CPT is indicated. And also, of course, clinical is also 4. So syrup cotrimoxazole is to be given in this child. And the question is when ART to be started in this child with TB HIV co-infection. So in this particular child, ART is to be started after completing 4 weeks of anti-TB treatment. So 4 weeks of anti-TB treatment. And within, of course, 8 weeks, corticosteroid is to be added because it is tuberculous meningitis. Next, continuing the case scenario 2, let us see when ART to be started in a cell with TB HIV co-infection. So timing is very important. So in a cell co-infected with tuberculosis, we have to initiate anti-TB treatment first. ATT is to be given first, of course, along with the co-thimerosine as per the requirement given by the AS. So ART should be started as soon as possible. After starting ATT within 2 weeks of the initiating the TB treatment, regardless of the CD4 count, within 2 weeks, among people living with HIV, if there is no signs and symptoms of meningitis. But in those children living with HIV and TB co-infection as tuberculosis meningitis, ART should be delayed at least for 4 weeks. Of course, initiated within 8 weeks after treatment of TB meningitis is initiated. So this should not be confused. So in other co-infection, as soon as possible, but tuberculosis meningitis after 4 weeks and before 8 weeks. Corticosteroid is given because of the tuberculosis meningitis. Next. So continuing the case scenario 2, the question is, what should be the ART regimen with dose prescribed for this cell of 9 kg? So ART regimen is AL, dolutegravir, and another dose of dolutegravir because of the tuberculosis treatment containing rifampicin. So abacavir, lamivudine, 60-30 tablets, 1.5 tablet twice daily with dolutegravir, which is 10 milligram DT, 1.5 tablet twice a day. And this is to be continued twice a day, dosing of dolutegravir to be continued 2 weeks of stopping, after stopping ATT. And after that, DTG is given once daily dosed. Next. So this is the modification of DTG-based ART regimen in children receiving rifampicin, which is already mentioned. So let us see DTG-based regimens. In case of the rifampicin-based, rifampicin containing drug treatment of ATT, we have to give double dose of DTG. And this DTG to be continued as twice daily for 2 weeks after the last dose of rifampicin. If happen to be giving DTG and lopinavir, ritonavir, we give double doses of DTG, and the super boosting of lopinavir and ritonavir is required to 1:1. Usual is 4:1, so it comes to 1:1. And this also to be continued for 2 weeks after the last dose of rifampicin. After that, the usual dose is to be resumed. Next. So let us see the first line ART regimen in ART-naive children living with HIV, which are co-infected with tuberculosis. So if the weight is less than 20 kg, then we give abacavir, lamivudine twice daily dose as per the weight band, and the DTG, which is given twice daily as per the weight band. And the weight between 20 and 30 kg children, we give abacavir and lamivudine twice daily dose as per the weight band of the child, plus DTG 50 milligram film coated tablet, that also twice daily. And if the weight is between 30 and above 30 kg and age above 10 years, then if there is no contraindication for tenofovir, we give tenofovir, lamivudine, and dolutegravir, which is once daily, and with added another dose of additional dose of dolutegravir, 50 milligram with a gap of 12 hours before the 12 hours after the drug. So, but in case of the drug-resistant tuberculosis, as there is no rifampicin, there is no requirement for changing of the DTG twice daily in case of the drug-resistant tuberculosis. Next. So DTG dosing for children living with HIV in drug-sensitive tuberculosis weighing less than 20 kg. Let us see the prescriptions. So between 3 kg and 5.9 kg, we give half tablet twice a day of DTG 10 milligram. For 6 to 9.9 kg, we give 1.5 tablet twice daily of 10 milligram DTG. And for 10 to 13.9 kg, we give 2 tablets of DTG 10 milligram twice daily. And for 14 to 19.9 kg, we give 2.5 tablets of DTG 10 milligram twice daily. If the weight is more than equal to 20 kg, instead of DTG 10 milligram, we select DTG 50 milligram film coated, that also of course twice daily. Next. So remember, DTG twice daily dose continue for two weeks after the last dose of rifampicin. But in case of the drug-resistant tuberculosis, as there is no rifampicin in the regimen, we don't require to give twice daily dose of DTG. Next. Let us see case scenario 3. Here, Master S is an HIV-infected boy of 7 years, asymptomatic. On examination, the cell is stable, no OI detected, weight is 24 kg. The CD4 count is 386 cells per cubic millimeter, hemoglobin is 12.6. Other investigations are within normal limits. The first question is CPT indicated in this Master S? No, because the age is more than 5 years and the CD4 count is more than 350. So he doesn't require this CPT, and moreover, he is in clinical stage 1 of the WHO staging. And let us see what ART regimen with doses is to be given in this particular side. So weight between 20 to 30. So we give ALD, abacabil amibidine, 60-30 milligram tablet, 3 tablets, once in the morning, 3 tablets in the evening, that is twice daily, with dolutegravir, once daily of 50 milligram film coated. Next. So case scenario 4, Miss T is a 13 years old girl, children living with HIV, ART knife, asymptomatic clinical stage 1, weight is 38 kg, hemoglobin is 10 gram deciliter, CD4 count is 458. So renal function test is within normal limits, under investigations are within normal limits. So here the age is more than 10 years, weight also more than 30 kg, that is 38. So CPT is not required in clinical stage 1, age more than 5 years, and the CD4 count more than 350. So let us see what ART regimen to be prescribed in this girl. So we will prescribe TLD because there is no contraindication for tenofovir. So children above 10 years, weight beyond more than equal to 30 kg. So 1 tablet of TLD can be given once daily, any fixed time as the patient's convenience. Next. So let us see how to do transition to DTG in a previously ART taking Synrent. So particularly in the first group with weight less than 20 kg. For this, the guidelines has been released on 14 August 2023, and this is to be followed. Next. Of course, DTG to be used 10 milligram tablets. So let us see very carefully these flows are for transition to DTG 10 milligram base ART in syndrome less than 20 kg, which is very important. If it is ART knife cell HIV, then we give abacavir, lamivudine, and dolutegravir as per the weight band. So this is very important. If the child is on ART or ART experience syndrome less than 20 kg, then we have to see for how long the ART is being given. If the ART is less than 6 months, if the child is on ART less than 6 months, then we continue, we do the transition to abacavir, lamivudine, and dolutegravir. Those, of course, as per the weight band and the viral load testing is not required. If the child is experiencing or taking more than 6 months of ART, then we have to do viral load before the transition. So if the viral load is less than 1,000 copies per ml, then we will do the transition to dolutegravir 10 milligram as per the weight band. If the viral load is more than equal to 1,000 copies per ml, then we have to do enhanced counseling. So for at least enhanced adherence counseling for at least 3 months. And during this time, we have to continue the same regimen. And after that, we repeat the viral load. If the viral load is less than 1,000 copies per ml, we do transition to dolutegravir, which is given in the next table. And if the viral load is more than 1,000 still, then we have to take guidance of the SASEF or pCoE. So let us see how is the transition in OLED in ART experience syndrome. So if the child, for example, is receiving abacavir, lamivudine, and lopinavir, ritonavir, if the viral is suppressed, we will change lopinavir, ritonavir to dolutegravir. That means ALD, abacavir, lamivudine, and dolutegravir. If the child is virally unsuppressed, then we have to see the hemoglobin. If the hemoglobin is above 9 gram%, then we change abacavir to zidovudine, then zidovudine, lamivudine, and dolutegravir. If it is below 9 gram% where we cannot give zidovudine, then we continue as abacavir, lamivudine, and dolutegravir. Of course, always we have to take the guidance of the pCoE or SASEF. Another example is that if the child is taking ZL and lopinavir, ritonavir, and virally suppressed, we will continue ZL and the dolutegravir, transition to dolutegravir 10 milligram. And if the child is unsuppressed in the viral load, then zidovudine will be changed to abacavir if not exposed to abacavir before. So this is to be remembered. If previously exposed to abacavir, then we'll still continue to take ZL and the transition to dolutegravir. So, and this transition is also to be taken guidance from the pCoE and the SASEF. Next. So this is something like quiz on transition of CL-ICIV less than 20 kg. So everything has been explained before. Let us see how this can be solved. So the situation is abacavir, lamivudine, and lopinavir, ritonavir. Viral load is 200 copies. So what to do? As the viral load is below 1,000 copies per ml, then we'll continue the same AL, and instead of lopinavir, ritonavir, transition to dolutegravir to be done. Same first line ART. And in the second case, ZL and lopinavir, ritonavir, then viral load is 800 copies. Here also we'll continue ZL and the transition of lopinavir, ritonavir to dolutegravir, same first line ART. AL and lopinavir, ritonavir, but viral load is 1,200 copies. And we repeat the viral load after enhanced adherence counseling for 3 months. Then here it has reduced to 600 copies. So we'll continue the same regimen, that is AL, and with the transition of lopinavir, ritonavir to dolutegravir. And in the next situation, ZL and lopinavir, ritonavir, but viral load is 1,800 copies. As it is more than 1,000, we do repeat viral load after ESC. And now the target not detected. So we'll continue ZL and the transition of lopinavir, ritonavir to dolutegravir. The first same first line ART. In the next situation, the patient, the child is on AL and lopinavir, ritonavir with viral load 1,200. So repeat viral load after 3 months of EAC. So now again 2,600, which is more than before. So we have to sense the ART regimen. Here we have to see how much is the hemoglobin. If hemoglobin is 9 gram and above, we can sense to zidovudine, lamivudine, dolutegravir. If the hemoglobin is below 9 gram, then we have to continue with abacavir, lamivudine, and the transition of lopinavir, ritonavir to dolutegravir. Here, the guidance of the SASEF and the pCoE to be taken. In the last scenario, ZL and lopinavir, ritonavir, viral load is 1,800 copies per ml. So we have to repeat viral load after ESC of 3 months. Then here also the viral load is more than before, 10,000 copies per ml. So we have to send ZL, and let us see what to be done. Here we have to see whether the child is previously exposed to abacavir or not. If not exposed, then we have to send to abacavir, lamivudine, and the transition of lopinavir, ritonavir to dolutegravir. If the child is previously exposed to abacavir, we have to continue ZL and the dolutegravir. Here also we have to take the guidance of the pCoE and the SASEF. Next. So these are the frequently asked questions on DTG transitions. So one pediatric patient who was on AL and lopinavir, ritonavir, his viral load was more than 1,000 copies, means requiring EAC and repeat. And we did not have pediatric lopinavir, ritonavir for 3 months. So we could not give step up. Hence, we refer to SASEF. What else could be done? So these are the situations, because for those 3 months, if we don't have the stock, then after 3 months, whatever may be the situation, dolutegravir is to be changed. So we can change to dolutegravir as there is no stock for lopinavir, ritonavir. What should be done if the regimen contains abacavir, abacavir coated tablet cannot be dissolved with dolutegravir? This abacavir film coated, so you can give abacavir, as we have mentioned already, you can give with crush or with water, or and to be taken, yeah, of course, immediately. Question number 3 is what to do with excess stock which is not going to be utilized till another 1 year. Then we want to see patient earlier to pediatric DTG as payload of pediatric LPV is causing adherence issue. With excess stock which is not going to be utilized till another 1 year. For excess stock, then it is better to use the stock, but according to the requirement of the situation of the child. So when to begin transition to DTG tablet after completing the present stock of tablet, lopinavir, ritonavir, or before that? So we can take now the recommendation is transition is being done. Next. So not only the ART, when we are taking care of a child living with HIV, we should always monitor some parameters like growth and nutrition in every visit, development and progress in every visit. In every visit, we have to do screening of tuberculosis by 4S screening. And we always monitor the child for any OI, and the treatment staging is to be monitored in every visit. In every visit, we have to calculate, we have to monitor, we have to assess treatment adherence, and very importantly, in every visit, weight is to be taken and the ARV dose to be adjusted according to the weight of the child. Next. So here some of the frequently asked questions about DTG monitoring regarding the blood sugar level. So blood sugar level in the question number 1 for 6 months, 6 monthly blood sugar level in the child to be done. So in the child between 6 years and 12 years, usual blood sugar level in the fasting stage is 70 to 120. And 2 hours after meals usually should be less than 140. So this can always be considered if there is increasing hyperglycemia in type 1 diabetic children with dolutegravir should be stopped or changed to other regimen. Dolutegravir is to be continued, and we have to do management for hyperglycemia by drugs and dietary recommendations. And in case of development of diabetes, so always diabetes mellitus protocol, treatment protocol can be followed along with DTG. In the question number 3, will child living with ICB to have weight gain on DTG 10 milligram? So based on the available literature, weight gain may be possible in adolescents as already observed in adults. So, but the long-term significant clinical significance of these weight gain and the changes are unclear. So therefore, further studies are needed in adolescents and children receiving DTG. Next. So let us see the case scenario 5 for calculation, particularly of the adherence. So here, Master Q is 6 years old, weight 13 kg, who was started on AL and DTG 10 milligram on 1st July 2023, and he has been issued 120 tablets of AL and 60 tablets of DTG 10 milligram. He is taking DTG 10 milligram in the evening 7 p.m. He has come for drug collection on 29 July 2023. That is after 28 days. So let us see how is the pill count in the box. So AL is remaining 10 tablets and DTG 6 tablets. So write prescription for this master Q. So we are giving AL and DTG. So AL 60 by 30 milligram, we are giving 2 tablets twice daily. That means 4 tablets per day, and DTG 2 tablets once daily, that is 2 tablets per day. So let us calculate the adherence. Next, for calculation of the adherence, we have to know the formula. The formula is number of pills given minus number of balance pill. That means number of pills which the child has actually taken divided by number of pills the child supposed to take, should have taken. So, and the pills the patient has to take is number of days into the daily dose. So let us see what is the calculation next. So number of tablets the patient on the day of dispensing, that is for 30 days, we have given 120 tablets because 4 tablets per day, 120 tablets, 2 tablets per day of dolutegravir, so 60 tablets. So next number of tablets should have been consumed is 28 days into 4. 112 is supposed to be taken. And for dolutegravir, 28 into 2, that is 58 tablets, 56 tablets supposed to be taken, should be taken. So, but tablets actually consumed is drugs dispensed minus drug remaining. We have dispensed 120, 10 is remaining, so 110 has been taken. We have dispensed 60 of dolutegravir, 6 is remaining, so the child has taken 54 only. So treatment adherence comes as 110 divided by 120 into 100 in case of the AL, 54 divided by 56 into 100 in case of the dolutegravir. So that is 90% adherence and 96% adherence. So drug for which the least treatment adherence is taken as the treatment adherence. So treatment adherence is average of 97%. Next. So to conclude, we have to do introduction of DTG dispersible tablet as pediatric formulation in below 20 kg. And this made the pediatric ART more potent and effective, and at the same time harmonized and simplified ART regimen across the different age groups, less than 20, between 20, 30, and more than 30. However, new regime has posed many implementation challenges, which some of them has been discussed. And remember, DTG is used across the different regimes. It is used in the first as well as in the second line treatment. And we are lucky that DTG is well tolerated, and the few side effects reported, which are usually minor and self-limiting. But don't forget treatment preparedness and adherence counseling. This is to be done at the ART initiation as well as during the transition to DTG-based regimen. Thank you. So these are the these QR codes which can be scanned and download in English as well as in Hindi for job ads. I think this is the end of the slide. Thank you.
Thank you so much, sir, for facilitating this session. Participants are
Welcome.
requested to please scan the QR codes and download the DTG 10 mg job aids for their reference.
Okay.
We'll also be sharing the recorded link of this session along with the PPT. So in the PPT also you will find these QR codes. Any
Okay.
questions from the participants? Please feel free to unmute your mic.
So I will be happy to deal with any question, any query from the participants.
Please feel free to unmute your mic. Mic access has been given to all. Sir, I don't think there are any questions.
Sweta
Yeah, yeah,
Patel,
yes.
there is no question, no more
No questions.
questions.
Yes.
So thank you so much
Thank
for
you.
the patient hearing and for giving me this privilege to present very important topic of dolutegravir overview and the case-based learning. Thank
Right.
you.
We missed it last time, sir.
Hmm.
Yeah, thank you so much, sir. Thank you to all the participants for patient listening. We'll conclude this session now.